Yes, I have controls, but I'm not seeing how. Is it wanting me to show slides or?
If you go in the bottom left-hand corner, you see
Got
them?
them. Yep.
Yeah.
Got them. Okay. All right, you're going to start recording. Welcome to our 4th webinar. We are happy to be here with you today, and this is Lori Call with the Illinois Public Health Institute. I'm joined by Antonia Lalagos, and unfortunately Anna is taking care of a sick child today, so she couldn't be with us. So it's just the two of us. And our agenda today, we're going to do this quick team introductions. We are missing 2 teams today that had to cancel, so it's just going to be a small group. We have 3 teams who will be on the call today, ADSWA, Livestream, and PIMA. And PIMA is going to be just a little bit late, so we're going to start anyway. We'll start off by just going through the work plan reports, and so we will give you an update from Sound Generations. They did submit one to us in writing, so we'll share that with you while we show their work plan, and then we'll ask ADSWA to give us an update on their work plan, followed by Livestream and then PIMA, and we did not get an update from MSU. So after the work plan updates and during the work plan updates, it gives you an opportunity to ask any questions of your peers, or if you have any challenges you want to talk through, you have an opportunity to do that, and if we can't help you, we'll try to link you with someone who can. Following that, we want to hear a little bit about how the technical assistance or linking with subject matter experts is going. We know that a couple of folks from the other work group cohort have requested some TA and connected, so we'll report on that, and then find out if any of you have had success connecting with any technical assistants or subject matter experts, either inside this collaborative or outside, and remind you of the process for connecting. And then we want to just review the collaborative documents and tools we've been working on throughout this collaborative and see if you have any additions to that. So that's the agenda for today. If you have anything that you'd like to add or discuss, please note it in the chat log, and we'll keep track of that. Okay. All right. So for team introductions, we'll just go through this really quick and see who we have on the line. So ADSWA, who do you have on the line today?
Tom Waltz, Julian Bond, and Jin Yao Q.
Great. Welcome, everybody.
Whitney couldn't be here today. She's not feeling well, so we'll cover for her.
Great. Sorry to hear that. How about Livestream?
Hi, yeah, it's just Paul Watkins today. Everybody else is at one of their main fundraisers today. So.
Oh, great.
Yeah.
Okay. Well, we're going to have a small but mighty team today. And is PIMA on yet? Okay. We knew that they would be joining. They are having a little bit of difficulty with audio, but it sounds like they are on. So they're working on that audio. By the time we get to the work plan updates, they'll be ready to say hello. So we'll just keep on moving. Okay, somehow, Antonia, I keep losing the control buttons. I see them now.
Every time I have to do anything on my end, I have to take them back for a minute. Sorry.
Got it. That's okay. If you do have to do that, just keep it on your end, and I'll know what you're doing. All right, so we're going to move to the work plan reports, and I know that you're going to give the report for Sound Generations. The format that we're using is what we sent out to you. Just any activities that you've completed or achieved in the last couple months, sort of successes, then also any hurdles or challenges you've been experiencing in the last couple months, if you want to share those with us and how you've been able to overcome that. Or if you're still experiencing a particular challenge or question that you'd like to pose to the group. Again, if the group can't answer it, we'll make sure that we find somebody who can. And then we just kind of close that out with if there's any certain tool or approach or process or activity, something that you've really gleaned or found useful, even something that you found that wasn't useful to save somebody else the time from going through that. Please feel free to share that and what you're prioritizing for the next couple months ahead if it's not already listed in your work plan. So that's the format we'll use, and Antonio, we'll start with you to give the update for sound generations.
Sounds good. So I'm just going to read the written comments that they submitted to me about their updates. So Sound Generation's work plan has been updated with timeline dates sliding forward, largely due to staffing, both internal and external, and system change initiatives. So largely due to staffing, both internal and external, and due to system change initiatives at external healthcare partners, disrupting conversations that were moving forward at the time of the Learning Collaborative start. They've continued their internal NIST review and researched alternatives to their Q1 external consultants due to the continued sliding of their timeline. And their IIT director is in Europe at the moment and returns next week. And so when they return, they'll have a more detailed reply. They finalized an updated vendor license with their external legal advisors and plan to port this language over to current licenses as appropriate upon their compliance manager's return from FMLA. And then they've shifted their focus on the referral loop to the information packet to be shared. They're understanding what the healthcare provider wants and plan to come back to sorting through the referral process when the opportunity reopens. They're working with Dr. Turner to garner funding for a grad student to help them in the summer and fall to work on seeking input from providers concerning presentation and transfer of EF and exercise-related data to the medical record. And I know that EF stands for, it's one of their program names, but they're working on transferring the data to the medical record. They were really sorry to miss the call. They just had a lot of different people out for very different reasons. So we're thankful that they were able to submit this update to us.
Yeah, thank you so much. Does anybody have any comments or questions for Sound Generations that we can pass on? It seems like pretty straightforward, but there may be something.
This is Tom Waltz in Vancouver. I had a question regarding a contact, or perhaps you can tell me more information about how they're transferring information to the medical record? Or is there someone there that I can contact? Or have them contact me?
We will connect the two of you via email. How's that sound?
Okay. That'd be great.
I would say Paige is the best person, but we'll put you through an email. Anyone else?
All right. Sounds like we can move on to ADSWA.
Good morning. The weather here is slightly overcast and very comfortable, probably 65 degrees. So if you're interested in weather, that's our report here. But beyond that,
Great.
Okay. So we made substantial progress understanding our data, what sources are available, and in what formats in. We're still trying to understand how best to access that data. A lot of our work has been facilitated by our collaboration with the Alterum Institute. We're receiving, continue to receive technical assistance. We received, as you know, a small amount of financial assistance, but most valuable to us has been the technical assistance. We've hired a data analyst, and that is Janiao Q. She's here at the meeting this morning. Janiao previously worked with Epic for about 4 years, correct? And she has an academic background in mathematics and statistics, and familiarity with the SQL data or SQL language, GIS, a little bit of Tableau. Some good background that we thought would be valuable to us, and so we offered her a position, and she accepted, and we're glad to have her on board. So she's been a little bit inundated. Monday was her first day, and we had an all-staff meeting on Tuesday, so she's been really inundated with the orientation process. And so,
excellent. Welcome to the team.
Thank you. So our goal is to put her in a leadership role within the agency in terms of data analytics. So we'll get that going, and looking forward. We're going to do, we purchased our Tableau licenses last week, and so we purchased 7 licenses, 2 creators and 5 explorers. And so we're going to start a training program, hopefully, well, sometime this month, hopefully as early as next week. But we have e-learning modules, and also we have an arrangement with Alterum whereby they'll pay for a consultant to provide us with Tableau training at a higher level. And they actually have a trainer already in place for us. So we're making arrangements for that. So we've made significant progress, and we're feeling really optimistic about what direction we're headed in. Hurdles, we're continuing to decide what the most useful and relevant ways are to use our data. I know that our folks at Alterum would like us to select metrics and make changes to the way we deliver services. And so one of the hurdles is, what would those metrics look like? What changes to the way we deliver services? What would the intervention look like? And how does that impact our program staff? So we're kind of working through that as a kind of a challenge. One of the other items that we're working on is the development of our scope of work for the demonstration project that Alterum is also a part of, or working with us to identify, and that's we call it our double duals, called the improvement program. Those are people that are receiving both Medicaid and Medicare benefits, as well as receiving case management and care coordination services through our office. So they're a high-risk, high-need population representing about 400 to 500 people. And so we're just trying to struggle with finishing up our scope of work, getting buy-in from our program people, and getting that accomplished within a fairly short period of time. Our Alterum contract for implementation of that project identifies us as having that completed by July 1st, and we're kind of wondering if that's a little bit too hopeful, and discussing with them about pushing that back a little bit. Is there a question for the group? One of the things we're kind of looking at is doing a profile of our population before we actually identify specific intervention or interventions. And so we're kind of wondering if other folks are how they're using their data. Is it oriented towards identifying their clients? Is it about collecting information about how the services are used? That's exactly a little bit more specifics about how others are using the data. In terms of our any tools, approaches, processes, I'm certainly happy to chime in. We've developed a draft of our scope of work. It incorporates a number of elements, such as a narrative of our double duals project, some of our goals, objectives, contains a work plan, It identifies a timeline, budget, as well as some exhibits, including letters of support. It's really a lot like a grant application in itself in terms of identifying what we want to do, who we're working with, how we're going to do it, what's the cost. It's still in draft form, and I'm going to turn it over to Jinya to finalize it, and we'll be working together through that. But that's a product that might be of interest to some folks in terms of it being a grant proposal design, and it might be of interest in terms of just understanding what the project is. It's about 50 pages, so just be aware it contains a lot of information.
Great. If you're willing to share that, Antonio, what's the best way for that to be shared?
You can either send it to me to post in the all-in private group, or you can post it yourself if you feel comfortable. It's up to you.
Okay.
Thank you.
As I say, it's draft right now, and we're probably a little bit premature. It's fairly well formed, but we probably want another couple weeks before it'd be available.
Okay. Great.
There's an item that's contained in the exhibits, which is data that we'll be using to formulate a profile of our clients. It's essentially a list of 110 items, data points. That is also sort of in this discussion mode in terms of draft, but it's something that we'd like to get input on from other folks. So actions in terms of the next couple of months, as I mentioned, completing our scope of work. We want to do this profile of our target population, and we also want to convene our collaborative governing board, which consists of Washington State University, Comagin, which is the QIO for Washington State, and a number of other states in the West. It includes also Washington State Aging Services departments, and a couple of others that a local hospital that we work with. So we want to get that board together as a sounding board to get us off on the right step in terms of implementing our double duals project. Let's see, in terms of the document partnering with healthcare.
Tom, we'll get to that in a few more slides.
Okay.
Yeah.
So there we go. If you have any questions, feel free to ask away.
All right, thank you. Go ahead, Antonio.
I have a question for Zijin Yao.
Yes.
Yeah.
I was wondering if you have any experience working with Epic Community Connect.
Yes. Actually, I was the technical lead for that program when I was at Epic.
Great. And I think there's some kind of string going on the All-In website about that. But we will follow up with you because there's several other teams that are interested in learning more related to this project. So
Okay.
we might tap into your experience a little bit.
Sure.
And then the other question I had was as far as the for Alterum paying for a consultant for Tableau, is that part of your participation in the other learning collaborative?
It is. It's not directly to us, but it's they had a set aside of funds through a grant from the Moore Foundation, and so as a part of that set aside, it was directly related to providing training specific to software utilization. They only used a portion of it and were interested in being able to use that funding for the consultant. and they actually agreed to extend the training component of the contract from June to September 1st on our behalf. So we're pleased that they were able to do that.
And is the consultant provided by Alterum? Do they select it, or do you select them?
They selected it.
Okay.
LTCI, I believe, is the organization.
The reason I was asking is because in the other work group there were people asking about their experience working with finding and hiring IT consultants, and so I was just wondering if that was your experience.
You know, I could get you the contact information for Alterum, and Laura McGovern is the project manager. She could give you more information if that would be helpful.
Yeah, that would be great.
Great, thank you. Do any other teams have questions or comments? I think the question that you posed to the group that you wanted to know about any feedback was related to this profile of the population. Is that right?
Correct.
Yeah, so anybody have any feedback or thoughts on that or questions?
Yeah, this is this is Paul. Tom, I don't know what access you have to like a lot of the public data sources, but a lot of times those are super helpful, especially like your state health department, county health ranking data. CDC has like a ton of different data sources that you guys could probably pull in. And actually, in addition to that, there's some that actually do some scoring. So the adverse disadvantage index is a good one to pull in, and they have kind of several factors that they kind of use a formula to indicate what those are. Those tend to be fairly solid. And then, of course, if you get any clinical data, like you can get ICD-10 diagnosis codes lists and stuff to match up against. There are like some zip code lists or address lists that you can use to kind of hash against to match up addresses, especially if addresses change or zip codes might be input into different formats. You can use like Python and R and some of the stats tools that you guys will be familiar with here fairly soon. But those should get you fairly far. And then on the Tableau side, Tableau has some kind of baked in demographic information as well. And then they also have some meetup groups that we've found here in Indianapolis to be really helpful. They'll kind of match you with people working on similar projects. So they may be able to help you out as well.
Okay. Yeah, we have a user group here on the west that I've been to one meeting and connected with a couple people that serve aging populations. So yeah, that's been pretty helpful. Can you tell me anything more about the adverse disadvantage index? How you get access to it? What it is?
Yeah, I can look up the website for, I think it's ADI.org or something like that. I'll have to Google it again, but yeah, I'll definitely send you that link or send it to somebody through the work group and they can pass it on too.
Okay. Thanks, Paul.
Yeah, no problem.
Anybody else? And Tony, I know you're familiar with a lot of those data sources as well in completing community health assessments. I don't know if we have a list somewhere of some of those resources that we could share. We used to. Do you know if they still do?
I'm sure someone in the Alliance for Health Equity has an updated one.
Right. Let's see if we can find that and share that as well. We do a lot of comprehensive community health assessments. using many of the data sources that Paul was mentioning. So maybe just sharing or posting that document with the data sources and links would be helpful.
Is the Alliance for Health Equity, is that a Indiana group, or is?
That happens to be one in Chicago and Cook County. It's the IPHI, the Illinois Public Health Institute, serves as the backbone organization for that. So it's a separate project from what we're doing now, but that's we definitely have a list of comprehensive data sources. It just may not have been updated for a little bit, but wouldn't take much for us to update and post for you.
Okay, terrific. Thank you.
Yeah. Anybody else before we move on? Okay, I think live stream is next, and Antonia, one of us switch the slide. Can't get it to move. I can't get it to move.
There we go.
There we go. Thanks.
Yeah, thanks. So, like I said, Jenny and her team are at one of their main fundraising events today. So I'll be speaking on their behalf with different projects we've been moving forward. So looking at the work plan, we're actually kind of wrapping up a good portion of this. We've got some additional data sources from related to like social determinants of health screening tools. We've got some external data sources in addition to like health system data. We've got some messaging data that we're also adding in. The biggest thing that we're working on right now is probably visualizing that information through Tableau. And if you've worked with Tableau, you can kind of create hundreds of sheets and various versions of those. So as we apply the analysis on top of it and kind of compile that information and then reiterate it, there's kind of, you can really pack in some pretty dense information into some of those dashboards. So that's what we're doing. The return on investment, that's the third one down. We've actually come up with TAM, SAM, SUM for their population. So total achievable market, the serviceable available market, and the serviceable obtainable market, if you're familiar with those terms. And basically we did that off of their Medicaid waiver eligibility, the populations that they're serving now through private and their traditional funding sources. And then we match that up to their demographic profiles, and basically have found that there's a large opportunity for growth, even though they initially assumed that they were pretty saturated in some of their areas. So now we can kind of pinpoint the counties to focus on different populations that may not be receiving our messaging, such as a Hispanic population or a Burmese population, for example. Based on CDC data and census data, we should probably be serving more of those individuals than are what currently being served. So it's kind of tying into some of that strategic planning as well.
Paul, can I stop you for a second?
Sure.
Did you, when you were starting to talk about the ROI, and it sounded like you gave an acronym before you talked about those three components. Will you say that again?
Yeah, so TAM is total achievable market. And then SAM is serviceable available market. And then SOM, S-O-M, is serviceable obtainable market.
I got it. Thank you.
Yeah. So TAM would be something like, what's the total population in your area that meets your criteria? The serviceable would be the percentage of people you think are eligible, and then serviceable obtainable market would be like the specific populations you want to target for services. So maybe people who are dually eligible, for example. So we built out business cases for those that we can kind of zoom in and out of, look at some of the growth opportunities. And Livestream actually just inherited a new coverage area as well, which basically doubled their geographic coverage. And and they're now serving closer to about 10% of Indiana's Medicaid waiver population as a whole. So it's opened up some opportunities there. So as we were diving into that, the other things we were looking at is beefing up some of those demographic profiles. So specifically looking at how many people with diabetes are we serving? What are the chronic conditions that are commonly coming up? What are the healthcare costs associated with those? And then from a caseload or traditional service line, they have various activities that they complete. So like quarterly assessments, annual assessments, phone calls, face-to-face visits, and that type of thing. So what we're doing is we're actually running that data through some algorithms, and we're partnering with another data scientist who's going to kind of come up with a caseload complexity scoring so that we can get a sense of where people are chewing up time for the case managers, if caseloads need to be consolidated so that everybody's not driving all over the place, those types of metrics. We've also got a risk stratification tool that seems to be correlating pretty well with some of the predictive models that we're starting to come up with, which is nice. So now they can kind of target a certain range within that risk stratification scoring. So 0 is the absolute lowest risk, and 1 would be the absolute highest. And depending on the populations they look at, the vast majority of their high-risk populations fall between 0.4 and 0.68. So we're really able to kind of zero in on those and then hopefully bend that cost curve a little further before they actually hit claims. So those are the main ones. Hurdles for us, which I think will always be a hurdle, is when we take data from multiple sources. So from like an insurance company or a health information exchange, they almost always have their own unique identifier, and they may have more or less information. So for us, as we match that with like a traditional case management application or a new one, basically what's the master ID that we should be using. And for us to do that, we have a machine learning process that we've started to build out to kind of look at, okay, what percentage of these are matching? How many clues do we have to say, yeah, this is probably the same person. So William and Bill Smith at the same address and the same zip code with the same phone number is probably the same person. That's oversimplifying it, but that's basically what we're doing. And there are some quote unquote hashing techniques that kind of speed that process up, that we match the data against a master kind of address, excuse me, address list that we purchased from the postal office. So we feel like we're getting some more clear information. We're getting closer to that golden data set, you could say. But the deduping process will probably be forever improving because of the complexity behind that. So,
Right.
Yeah, I don't want to take up too much more time.
We can pause for see if anybody has any questions or feedback.
Sure.
Tom in Vancouver. On the risk stratification tool, Paul, what data does that include? Or can you tell us a little bit about it?
Yeah, so the vast majority of it are based around like medication risk scoring tools, evidence-based models around hospitalizations and readmissions, different factors related to chronic diseases. So there's chronic disease code lists that we look at. There's like a super slight difference between like gender, for example, mostly because females tend to live longer than males, but we can weight kind of different metrics throughout the risk stratification tool. But basically, right now it's a blend between like their inter-RAI assessment data that they get for their long-term services and supports to say if somebody qualifies for their Medicaid waiver program. It's a blend between that information and some of the claims data they get from like their health information exchange related to like hospitalization rates. And it sounds simple, but it's a pretty big lift by the time you get to the accurate information underlying that algorithm. And there's another algorithm that kind of feeds it as well called the MAPLE that's used to kind of risk stratify members as well. So it's kind of a blend of kind of a series of risk stratification tools that come up with this overall scoring.
Thank you.
Yeah.
This is Jinyao from Vancouver. What's the size of the data that you're using to, or you're dealing with daily or for this project?
Yeah, so you mean like the sample size or like the population size?
Population size and sample size, I guess.
Yeah. So population-wise, if we're only looking at Livestream, they serve about 7,000 members month over month, and then they have a healthcare contract that they get data from a health system, and there's about 2,000 members that come across on that they get referred for. So in total, you're looking at between 6,000 and 8,000 members. But total number of records goes like, if you're looking at all the claims data, all the data points that are underlying in that, you're getting into about a terabyte of data, I would say, by the time you spin it down. Yeah.
Thank you.
Sure.
Anything
Paul,
else?
Tom again.
Seema, anything?
Yes. Tom again in Vancouver. You mentioned social determinants of health screening tool. Can you tell me a little bit about that?
Yeah, so here in Indiana, they have a specific social determinants of health department that they spun up under basically their health and human services side. And she developed a series of like 10 to 12 questions that are asked, and it uses some skip logic. So all of the area agencies on aging in Indiana are using that under their options counseling and case management processes. So then that data actually feeds their case management application so that we can correlate that information. And I know the lady from Indiana would love to talk to whoever, so we can get you in touch with her if you're more interested in that actual tool.
Absolutely, yes.
Okay.
Can you also share that, the questionnaire tool?
Yes. I'll have her send that along because I know she kind of controls the documents and updates it and that type of thing. So.
Okay.
Yeah. I've spoken to some folks in Missouri as well, so I don't know if they're using it or not, but I know she'd be happy to share it, I guess, is what I'm saying.
The risk stratification tool, is that something that you can share as well?
Maybe. Let me look at, because there's like several factors in it, and some of it's proprietary to us, the way we kind of crunch the numbers. But I'm sure we can tease some of the elements out for people to look at and then send it your way.
Okay.
Do you folks have a confidence level on the risk stratification tool?
Yeah, so I'm sure you've seen like in Tableau, they kind of have confidence intervals that they can help you kind of calculate as well. But on our side, like the confidence intervals are looking pretty good, between 0.85 and 9 at times, depending on which data set you're looking at. But we know there's room for improvement with it as well. because people are people and they're going to change. And plus, as we clean up the data, we find like the more accurate the information, the more we can kind of tweak that risk stratification tool to be a little more accurate.
Okay, thank you.
Dima, any questions or comments before you give your update?
No, I don't think so from us. I think that was pretty clear from Paul.
Okay, great. Great. Well, then we'll move on to you, and thanks, Paul.
Sure, no problem.
All right, I think I have your slide up now.
Yeah. So we've been, we're mostly right now working in the goal 3 area of the bottom 2 activities, the vendor negotiations and spec pieces. And we've gone away from actually looking at purchasing a whole new system and are concentrating pretty seriously on expanding our use of the GetCare product that the state has implemented for the AAAs around the state. And that's where basically our negotiations have gone, is trying to negotiate with the state in getting them to be more of a partner in getting what PCOA sees as a good expansion out to the entire state for a number of reasons. Of course, budgetary, it would be beneficial for us if we spread the cost over all the AAAs, or if the state opted to purchase the system, or the additional modules. And that's where we are right now. And luckily, it's actually just before this call, we got off a call with the state folks, and they're very open to that approach. So our negotiations now are moving towards the state and us building some specs together and approaching RTZ potentially to expand this out to the entire state, which I think will help. And like I said, the statewide cost sharing, statewide data collections, data measuring, and then that gets us into what we're doing as far as collecting and analyzing data. And currently we're looking at an additional piece on analyzing the data and getting into predictive models and things like that. And we're also trying to sell the state on that. And what we've been doing to get there is I've had quite a few discussions with other folks around the country. Anna connected me with a couple, and that has led to multiple connections and has prepared me for some of those discussions we're having with the state. So that has been an extremely beneficial part of this for us, that in those discussions with other agencies around the country, some who have used GetCare or are using GetCare, so they had very specific feedback. Others who have gone through the same process we've had, I've been able to then engage and learn from them to kind of approach the state with that. And we think that's helping because, like I said, the call today and a couple of discussions our CEO has had with folks at his level at the state have been very promising so far. Unfortunately, this means that it may push our timeline out a little further than we wanted. Right now, it looks like we're could be on that timeline, or we may be out a couple of months. We'll see in the next few weeks as we start getting into the specifications of the changes we might need on a statewide level, and then getting buy-in also from the other AAAs, not just the state entity folks. So In the email that Antonia sent to us for our update, that kind of covers A and B for the most part, kind of what we've done and some of the hurdles that we've overcome. The last time I reported, I believe that we thought that the state was going to be a much larger hurdle than we're actually encountering. So that's really good for us, and not just PCOA, but statewide, like I mentioned. So for the next few months, the next couple of months, we're prioritizing getting those specifications done now. So that becomes basically, like I said, our negotiation and spec design. So we can then go to our TZ as a larger entity and get a lot of that done. Secondly is working further into a pilot project we're engaged in right now for data collection, data warehousing, and visualization. And hopefully next time we do an update, I'll have a lot more detail on that. So those two aspects, I think, are our priorities for the next 1 to 2 months to get us basically where our objective was as when we started this collaborative. As far as working with managed care, I think right now is we're feeling more confident about our ability to go out and engage with folks from managed care, not feeling that we have to have the same system that they do, not necessarily having to have the same approach that they do, but that we are able to speak in a way that shows them that we're capable, I guess, and that we're knowledgeable, and that we, through the process we're going to go through, that we have hard data to really back up what we're trying to advocate for. So I think that's where we are right now, at least feeling more confident that we can do this, not having yet actually tested whether our confidence will prove fruitful or not. That's the majority of our update. A lot of discussions, but very promising and forward-moving discussions.
Thank you. Thank you. Any comments, feedback, questions?
This is Tom in Vancouver. What relative size is PCOA in terms of the other AAAs?
We're the second largest in the state. So we're Pima County, which is the Tucson, basically the Tucson metropolitan area and the surrounding area. And we have a lot smaller population than Maricopa County. So that's the Phoenix area. That's region 1 as far as the AAAs. We probably, if you take all of Pima County, I should know this number, but we're probably talking 1.5 million population, whereas the Maricopa County is easily 6 times that, if not more. But compared to the rest of the state, we are a major population area. So the rest of Arizona is pretty rural. So there are 6 AAA regions in Arizona. So region 1, which is Maricopa / the Phoenix area, and region 2, which is us, the Tucson area, are the 2 largest. Everybody else has populations of towns that are probably in the 20 to maybe 50,000, and big. I mean, we're talking rural population areas that may span 100 miles or 200 or 300 miles in some points from end to end. So we're the largest, and we're the second largest. I mean, but much bigger than all the others. And we really offer a lot more services than just the Older Americans Act, the traditional AAA services, to our community, our Pima County community. So we are spread out quite a bit as far as the types of services that we can offer. If it's aging related, we offer it, and then we have additional arm of the agency that called Pima Care at Home, from home health services that offers a lot of other services too.
So you do direct in-home services? You don't contract for those?
We do contract all those. Yes. We do all the case management, but for the most part, through that, our home health services are contracted, but we do provide some of both because of that other organization. Does that make sense?
Sure.
Did I say that you were? I'm sorry. As PCOA, we contract out for the cases that we case manage, and then our Pima Care at Home is contracted by other providers to serve.
It sounds very similar to ours. Did I hear you say that you folks were customizing the Get Care product for your area?
That is now what we have decided to look at. So we're going to, as far as PCOA goes, we're going to get more detailed into all the mapping of how our services interact on an electronic system. We're going to take that to the state. That's what we agreed to this morning. And then together we're going to come up with the specifications on how that currently fits into Get Care and where we may need some customization, and then go to RTZ with that, the vendor for Get Care.
So is that customization so that you could go outside of the Older American Act programs to collect data?
Correct. That would mean that all those other programs that we offer could all be in that system, and that likewise that would work for the other state AAAs. That way our entire populations would be under one system, but identified as such to the data that the state needs, so they can pull their own information, yet each agency can access all their own clients. That's the goal anyway.
Okay. Last question is: do you know if Maricopa County is doing that same thing?
Maricopa County is less likely to follow in those footsteps. They're much bigger, and the AAA in Maricopa County is tied into other Maricopa County systems, so it becomes more difficult to pull them out of that and try to get them fully on board. So even though they are the largest, the majority of the population in the state, all the Older Americans Act data we can look at collectively. The rest of it we'll kind of address at that point to see how we can look at it collectively.
Okay, thank you.
Anybody else have any questions or comments?
This is Antonia. I just had a quick comment and question. Just to let the Pima team know that I visited Tucson recently and really liked it. It was my first
you didn't
time
stop in to see us.
I know, I should have. It was my first time in the Southwest, so it was really neat.
Cool.
But besides that, I was wondering if when you said you were more confident speaking with managed care and you were able to speak in a way that shows that you're capable, was there any particular resource or conversation that you had that you found helpful for that process, or has it just been kind of this whole process getting used to, this whole process has conditioned you for that?
I think it's the mostly the latter. It's this whole process has conditioned us for that. There were some very specific conversations that I had, and I'm so bad with names. Kathy Vesley, I believe it is, in Virginia, if I have the name right. A conversation I had with her, Bay Aging, I believe it is, in Virginia. And then she kind of referred me to somebody in California. And those two specific conversations were real helpful to me. Hers on how to talk to other folks, and then she referred me to California with folks who have been using GetCare, and I learned about their experience there. But I think overall, it really has been this whole process. Has conditioned us, I think, to learn in how we represent ourselves, understand what managed care may be looking for, and then how to talk to them.
Great, thank you.
Yeah, and on the data visualization process, Paul with Livestream just spoke ahead of us. So we are working with translating data, Paul's company, to look at how our data might look if we went with something like that, and then our hope is that if all that works out, that we can then present it to the state. And luckily, Arizona right now is really interested in the predictive analytic part of it. So I think that gives us a way in, hopefully.
Great,
Very
thank
good.
you.
Antonia, I am just going to turn it over to you now to take us into the next section.
Okay, sounds good. So this portion, we're just going to talk a little bit about the TA and subject matter experts that the teams have been working with. So we just wanted to update you on Workgroup A, age options, connected with Network for Public Health Law recently. Oregon Wellness Network is working with Sharon Fosco from the Council on Aging of Southwestern Ohio. They were speaking about Care Director, and I'm just forgetting the other thing they spoke with her about, but that's ongoing. And then Tim McNeil has been working with Western New York, Oregon, and Maryland on their end as well. And then I've heard several on this call speaking about some connections that you all have made. So we just wanted to ask if anybody has been working with subject matter experts inside or outside of our learning collaborative that you would speak to or recommend for the group. And just as a reminder, we'll go over the process of requesting TA and subject matter experts through our little form. But I wrote down some of the names that you guys all said. I just wanted to double check to see if anybody else had reached out or wanted to reach out to any of our experts.
If anybody's talking, you might be on mute.
This is Tom Waltz in Vancouver. We have not reached out to a subject matter expert. We do still want to talk with Sharon, is it Fusco?
Yes.
And so if that's something that you folks can help us arrange, that's great. We actually did try to reach her. We exchanged emails and couldn't get our schedules cleared for that particular time. And so since some changes in our office, it would be advantageous to us to schedule something later in this month, if possible.
Great, yeah, and she's formally working with teams, so the best way to do it would be to fill out the form really quickly just to have it documented, because she looks at that form to see if anybody's also requesting, and we match you up to the expert. Either you request her specifically, or if you had some other kind of request on a different topic, you could put one in through that form and we'd find somebody to help you out. But we'll definitely get you connected to Sharon.
Okay, thanks.
Is there anybody else? So just
this
as
is
an
Victor
overview.
from PCOA.
Oh, go ahead.
No, I just wanted to say I was holding off. We have not reached out to him, to SME. We were holding off, and today with that call with the states, as they've committed their technical folks to work now at this approach. That's probably the route we're sticking with.
Gotcha. Okay. So just as if anything comes up in the future for any of the teams, we have this short request form. We look at the form, we get a notification when it's filled out, we respond and match you to the SME, and your team works with them to schedule the call and document the topics you discuss. And when you document your call, you'll be sharing again on the call like this, either in the full cohort if there's time, or in the work group again, what you learned, what takeaways you had from the process. We kind of did it informally through the work plan reports this time as well. But and then the SME is also documenting on their end what you all talked about, so that it can be shared with others. So moving on from that, Lori, could you do the next slide? Just as a reminder, these are the topics that are available in the form, and we pulled these from a list of your evaluations, your one-on-one calls, and the office hours, and tried to group them into different areas. If you look at the list and think these aren't the right topics, let us know. If that's not how you've been thinking about it. It would be helpful for us. But it's basically just a checkbox for you to say kind of what your request falls under. If it's under one group, one topic, or multiple, you can check multiple. Okay, so we can move on to the collaborative documents and tools. This is where, Tom, we can jump in with your addition to the key takeaways document. So this document was developed in January and hasn't been revisited much, but we really wanted to try and see if we could build out a little bit more on the question, what data infrastructure components do you need to contract with healthcare? And so I'm going to pull up the actual spreadsheet and put it on the screen. And I was wondering if your team had anything to share for this document. I see that there were some things added. Would anybody like to share what they put in?
Yeah, so one of the comments that we were kind of touching on for like tips if we were to start from scratch again, that type of thing. Really keeping track of like the versions of the data that you get in, especially if a health system is updating their information on a regular basis. Their formats change fairly frequently, even if it's just moving a couple of rows or columns or something like that. But really kind of nailing down like which version of the data format are you working with, and then getting them to work under your data structure as much as possible. Oftentimes through your extract, transfer, transform, and load process, or ETL process, you can take those data points and map them to yours. So if you have that capability, definitely kind of push hard on getting them to use your format, which is typically doable, especially if you're willing to do the mapping. From there, we've really started looking at, like, how are we asking questions with the data, and as smoke kind of arises, what's our root cause analysis process with that as well? And then does that root cause analysis actually address what we're trying to communicate to whoever's trying to use that information, whether it's internally or externally or with staff at various levels? And then, of course, including in that root cause analysis, the methodology and the consistency that information is gathered. So if you can kind of track, if you have a questionnaire with 10 questions on it, and you have a series of people who consistently are only answering 3 of those questions, maybe that's something you can meet about, to say, hey, these are the key points of information and why we're gathering that. And then the tools, there are a lot of different tools out there, a lot of different applications you can kind of lay on top of your data. There are different data warehouses that are starting to pop up as well. And if you do implement a process, hopefully it's one that aligns with your workflow and your business case as well.
I think we got put on to hold music. I'm not sure.
You have reached Gold Canyon Internal Medicine.
Can we just mute all lines except ours?
Sorry about that, Paul.
Oh, no, that's okay. I use a little music sometimes, yeah. So yeah, the processes, there's a lot of different processes out there. Lean Six Sigma was a big one for a while there. There's various kind of approaches to a logic model. There's a lot of different consultants out there that will kind of look at your workflow a little bit differently. But don't underestimate your industry expertise that you bring to the table. To be honest, the data geeks cannot do their job without the input, and a lot of input from your local experts on the programs that you're delivering. So feel free to participate as frequently and as often as possible. And those are some of the things that we found work for us, at least.
Great, those are all very helpful. I'm going to move your text into the actual document when we're done, but does anybody have any feedback on what Paul was presenting? I'm going to unmute some lines. I think Atswa and Pima, you're open now. Tom, did you want to speak about the tips that you had wanted to add?
The only thing I was going to discuss was the importance of relationship building and identifying or selling the services or commodities that you have to offer, and recognizing that, a government-provided service relative to private sector are oftentimes viewed differently.
Thank you, Tom. And Pima, did you have anything to add?
I don't think so, but that just piece that Tom just said about relationship building, I think everybody that I've spoken with, when I did our update, I said I've talked to folks across the country. Every single one of them emphasized building relationships and the importance of what that has meant to them over years, not just approaching somebody cold, but actually taking the time to build that.
Great. Thank you for adding that. Anybody else have any thoughts they wanted to add to this? This document is open. It should be open to editing by anybody. So if you come in and put in things later, feel free. So I think we'll move to the next tool, which is the vendor software tool. I just wanted to ask quickly if anybody had any new demos or any learnings they've had related to the systems that they're using. Feel free to jump in. We are planning to ask for some volunteers from the group to look at these attributes on the top row and help us find standard definitions or more standard definitions that speak and resonate to you as AAAs and CBOs, using the definitions that we've found in the Siren and Idealware reports that we've shared. We thought that those provided pretty good standard, not having to reinvent the wheel, so we could just pull from there and get your input on what it would look like, or if there's anything missing up on top. And then ultimately, this list will probably be pared down to kind of the most popular, the most frequently used systems among the group, and it won't be a full review of all of the many that we have listed here, almost 30. So we'll follow up with some information about how you can continue to update this spreadsheet. And then the last thing I wanted to go over is the resource list. This we just developed to try and pull together all of the great resources that you all have been sharing, either through the All-In website or on the webinars as we can capture them. The best way for us to keep track of all of them is through the All-In website, posting them in the home page of our private group, or sending them to me and I can post them for you. So I've just started to compile them into kind of a bibliography almost of tools, articles, reports, webinars that you and IPHI have suggested, and we're going to have a kind of a process for teams to give their input on the utility of the tool or resource, some feedback and comments about why it was useful or why it was not useful, and what some key takeaways were for your organization on a similar journey. And then looking at how useful it is for different CBOs who are at different maturity levels as far as their health information technology. And we split it into 4 stages: early investigation, selection, implementation, and active use. And there's also a way to select that it's not relevant for this journey. And then finally, we have created this list of tags that was generated from your feedback and all of the evaluations and one-on-ones. So the way we're going to go about this is probably have you fill out a form to make it easier instead of inputting it directly into this spreadsheet. And what we're going to ask groups to do kind of a review of 2 resources they've already looked at and then 1 that you haven't. So we kind of have as much of the different resources kind of reviewed and vetted, and then we'll be compiling it into another deliverable, another tool for as a product of this learning collaborative. So I'm going to stop right there and just see if you have any questions about this or any suggestions about how to make this easy to do. And I would add, this isn't the full list. I'm still going through the things that have been posted on the All-In platform, and I will definitely have some things to add from today's call, so it's going to be a growing list. Okay, well, if there's any thoughts or comments you want to submit in the evaluation, feel free to do so, or you can email me directly. You'll be hearing from us soon about how we're going to go about doing this process. So finally, I'll go back to the presentation. So just to let you know, our next webinars, the next webinar is the full cohort number 5 on Wednesday, July 10th. Currently, we have USA doing a presentation about bidirectional e-referral, and we're also looking to find a complementary presentation for that date. We have work groups coming up. Our last work group is Thursday, August 8th, and then the last full cohort is Wednesday, September 4th, and we have Lori Peterson of Collaborative Consulting reviewing the Trailblazer tools that have been developed, which we touched upon briefly at the last full cohort call, but there wasn't enough time to go in depth, so she's going to be talking about those in September. And then here's just a review of the next steps for homework. You can submit their TA requests if you desire, and then just make sure you document some of what you talked about so that you can report out on our next meeting. We're going to solicit volunteers to help us define those attributes in the vendor software diagram, and we're going to follow up with the HIT resource list and have you review and comment on at least 3 of those resources by the end of June, or at least before the next call, so we can get that moving along. So we just wanted to probably end a little early because we had a smaller group, but thank you very much for all of your participation and feedback. Definitely going to follow up to get those resources from you. And then if you could just have one person from your team fill out the eval before you leave, we appreciate it. Lori, did you have anything to add?
No, thank you so much.
Great. Thanks, everyone.
Have a great day.
Thanks.
Thank you.
Bye-bye.